So thanks so much to our speakers. Regenerative medicine is such an area where there's so much passion and energy right now. I've worked in pharmaceuticals for over 20 years. We've put all kinds of chemicals into people, all kinds of plant things, and it's great to talk about human-derived ingredients, just a real change. So thank you so much to our panelists. You guys all have incredible practices across the country. So I'd like to start with you, Dr. Bucky. You have 3 practices in Philadelphia. Tell us a little bit about what your patients are saying regarding regenerative medicine.
I think patients first got introduced to regenerative medicine probably through skincare and back in the day of Skin Medica and TNS. And if you look forward, you need to look backward to look forward. And I think it's been a slow process that's quickly ramping up. I think in my practice, in our practice, there's actually an entire office, a 4th office, that's really based on using regenerative medicine as a big part of body contouring, body health. But I think that patients follow along with physician enthusiasm. And in the world of plastic surgery, they look to us as being the people who certify and credential what's going on. It has to resonate with what patients want to hear. And so PRP became fairly commonplace. Media has presented it. But we know that it has a high failure rate. I call it a 90-10 technology, where 90% of patients get a 10% improvement and 10% of patients get a 90% improvement. And that is very hard to commit to. So I think that as the science improves, and we've heard some of that today, physicians will be able to get excited, and we'll be able to communicate that to our patients. And I think industry has 2 clients, the doctor and the patient, and you guys are always back and forth trying to figure out, should we go direct to consumer or should we go to physicians? In the case, and I'm sorry to be long-winded about it, in the case of this, the science is too complicated for patients alone to understand. So you need to have both on your side. And I think it's still taking time to understand what's happening here so that we can emphatically support some of the new regenerative things that are happening. And unfortunately, some of them are on label, some of them are off label. Photos demonstrate some good results, some not results. So we're in this sort of murky area with great hopes and great expectations.
You bring up a great point. In 2019, the FDA actually issued a letter warning that there was a lot of companies out there talking about claims that were off-label, unsubstantiated. So Dr. Davenport, tell me a little bit about how you deal with that sort of thing in your practice, and patients come in and they ask you, they want these miracle cures. How do you deal with that?
Sure. So I'm from Long Island Plastic Surgical Group. There are 27 of us now, and there could be 28 because I haven't really called in this morning yet. So, and those of us who know about plastic surgeons, it's kind of like herding cats and getting a consensus for something like this. But I think when you're dealing with patients, part of it is they're entrusting you with vetting everything that's out there. And you develop a reputation, and that part of that reputation is you've already done the research, you've worked with all that. And I think patients respect it when you tell them that they're wrong and that what they want is probably not something that is ready for prime time, and that you will certainly monitor that. And part of my job, I tell them, is vetting the technology that's out there.
Thank you. Dr. Cohen, you actually founded the Cell Society, which is an international organization dedicated to educating on regenerative medicine. So tell us a little bit about what some of the hurdles are around education in this space.
Well, to large measure, we don't read scientifically. We listen to KOLs, and the loudest one often wins. So I think as we do process these scientifically and we show results that are actually measurable and repeatable, I think that we have to take wind of these things as perhaps being better approaches. So I do think there are ways to segregating this. For instance, when we talk about PRP, the device that makes the PRP, the higher number of cells, when you do meta-analyses of multiple studies, the only ones that have shown efficacy are ones with high cells. So if somebody says, here's a box that makes PRP, wonderful, you're doing PRP in your practice, but you may be using something that actually doesn't work at all, even though it's PRP. So I think education of physicians is critical, because then we can actually explain to our patients what regenerative medicines are like. These are not home run therapies. These are therapies like going to the gym. These are therapies like changing your diet and living 15% longer. So if somebody says to me, stop eating this food and you're going to live 15 more years, I go, well, that's not that bad. I don't really like string beans or whatever, so I'll stop. If somebody says to you, if you begin the habits of replacing your tissue as it's being lost, well, what is nuclear decay? It's what you start with, it's what you end with, and the rate is determined by how quickly you get there. Well, our genetics determine the rate. So these failures in large studies may truly not be failures. They may be failures of the cells we're working with and our failure to identify who is really going to be affected. And again, also finding out what is the true messenger, what is really communicating with the cell. Is it only the exosome? Will it be a need for exosomes and matrix? Most of what we do in plastic surgery are going to require a matrix or scaffold, cells and signals. So, that we're always going to be needing, at least to the present time. So I would be very excited, but I think we have a long way to educating physicians. We keep referring to articles written 10 years ago on fat grafting that are such nonsense, it's pathetic. I mean, why? I'm not that smart, and I can look and say, why am I putting fat in every single part of the face? I'm putting it for an aesthetic outcome. What a bunch of nonsense. Put the fat where it belongs, not where it doesn't belong. And if you're trying to get a regenerative effect, then you want to extract the basic molecules, which may turn out to be exosomes, and use those for regeneration. So I think as we learn more, we will become actually much, much better at treating our patients.
I knew when I saw you spent 3 years at University of Michigan, you would have a great response on that.
Thank
Go Blue.
I was thinking more at, the Heart, Lung, and Blood Institute, but thank you.
Dr. Davenport, you did a fellowship in burn and accident at Shriners Hospital. A lot of the initial studies for regenerative medicine were in wound. If you think about where you've incorporated it most in your practice, where has that been?
Sure. So I have a practice which is both reconstructive and cosmetic. My main cosmetic population is my mother's friends, so that's the most dangerous practice you could probably ever have.
Those are the best patients.
So, but one of the things that regenerative medicine started is with wound healing, wound care, and really plastic surgeons and burn doctors have really been a leader in those areas. I think really the superstars of regenerative medicine will be in the aesthetic space, because they have the added competition of these products and these treatments and these systems need to be made cost effective. And at the same time, which I could not agree more with what Dr. Bucky was saying, was that the demand for efficacy is so high in aesthetics. So here you have these regenerative medicine properties and products which need to have a 90% efficacy with low cost, which is something you don't see in burn and you don't see it in wound care, because if you could heal a wound 30% faster, people are very happy with that. And that's an overwhelming success. If your filler lasted 30% longer, people would still be complaining that it doesn't last long enough. So, so really this is, the bar is, and I really have to really hand it to these doctors, these teams that are doing regenerative medicine and aesthetics, because you have the highest bar in medicine. So, congratulations.
I think,
And,
well,
good luck.
The good news is that regenerative medicine resonates very well with patients. They like it. We had, in response to what Steve said, fat got very popular because patients understood and had very few hesitancies about taking their own fat, a benefit, and putting it someplace else, a benefit. So there was very little resistance. The only resistance was really from the docs that it was cumbersome, and we've made a lot of strides for making it easier. In the same time, in parallel, we've developed all these off-the-shelf opportunities. And so I think the idea of regenerative medicine, again, resonates very well with patients. I think there's two types of docs, and most of them, the early adopters are in this room. They're interested. Their minds are interested in innovation and early adoption. And then there's the more cynical late adopter. And you can't appeal to everybody. And I think patients come that way. But if a physician knows what his patient wants, and these things resonate well with patients, then patients sometimes drive demand for better or for worse. And the last thing I'm going to say about it, where I think Tom has a big advantage, is with regenerative medicine in injury, in the face of injury, that's a perfect model for tissues to heal, regenerative stuff to work, because the stimulus is there. We're trying to take this in healthy people who haven't been injured and see if you can make it better. And probably the answer is going to be, we're going to have to create some sort of injury response at the recipient site, whether it's microneedling, lasering, or whatever it is, so that you can get a more demonstrative result than just putting something on healthy tissue and thinking that you're going to get a good result.
I was going to say, Lou, I think that aging is an injury, a cumulative injury. So
God, am I injured?
Yeah.
Yeah.
Absolutely. So if we think about 5 years from now in each of your practices, really, how do you see regenerative medicine be a part of it then versus how it is now? And we can just start with you, Dr. Cohen, and go down the line.
Well, I kind of am focused on facial aging. So I look and I say, patients are going to continue to come in my office with 4 things: sun damage, volume loss, which is not air, it's specific, losses in specific tissues from skin to bone; 3, laxity; and 4, facial movement, which is more of a facilitator. That's the only 4 things we treat. They're going to be impacted by genetics, and so we're going to be able to give them a detailed roadmap as to how to treat themselves and perhaps how frequently to treat themselves. And I think they're impacted by, obviously, internal, external environment. So I think instead of waiting for the inevitable, we're aging, we're going to challenge the inevitable by understanding, like heart disease. We know in a newborn who's had all of their male people die in their family at age 39 that they're in for a problem. Why wouldn't we put them on Lipitor? Why wouldn't we start regenerative therapies before the disease surface? Because we know it's coming. So to me, as we look at regenerative medicine, we really need to focus on medicine in general. And I think this is why this field is poised to become, mega in the future, in my opinion.
Absolutely. Dr. Bucky?
Yeah, I don't think it's a fad. I think we're going in that direction. To predict the time frame, I think that we have at our disposal now a lot of controlled injury treatments, lasers, microneedling, things like that. We've already seen products that are being touted as to be utilized with treatments. And I think that's where we're going to see the first real difference in our before and afters. There's no question, though, that as we get clearer as to, for instance, exosomes, the role of platelets, what's been described, how to maintain those tissues instead of just throwing things at it, we will be better. I can't tell you that it's going to be mainstream, but I would predict that we're going to continue to grow. It is not a fad. And the other piece is, as innovation happens, you get clear as to why you're doing it. Are we doing this for volume restoration and structure? Are we doing this for environmental damage? Are we doing it for anti-aging? Or are we doing this for wound healing? The beauty of regenerative medicine, if you will, is it applies across the board, and different areas will lead and other areas will catch up.
Thank you. Last but not least.
Sure. So, I'm a big proponent of regenerative medicine. It's part of my research, and I think we are at an inflection point that we were looking in different directions. We were looking at different fillers. We were looking at Botox. We were looking at non-invasives, and that was kind of our focus for a while. And now in aesthetics, our focus has changed. And I think at this inflection point where we now have a deeper understanding of how these systems work, and exosomes and stem cells and fractionates, that this is the direction that we're looking, and this is the direction we're going to develop. And I think in 5 years, we're going to, the same way we had one filler 20 years ago, we're going to have 10, 20 different products, and this is really what the patients want, I think, at this point, is something that is natural, that comes from themselves, and has this regenerative property.
Steve, how long have you been doing fat?
Well, fat, you know,
Fat injection in general. First time you ever injected fat in someone's face. How long ago?
probably in the mid-'80s.
So almost 40 years. So what's 5 years on that plan? How fast do things go in 5
Well,
years?
Lou, to me, I don't look at fat grafting as, I mean, yes, it's regenerative, that's kind of serendipitous. I look at regenerative as the discovery of these cells in fat and the deployment of them. So to me, that for me began in 2000 with the findings from Pittsburgh and UCLA.
20 years.
And the first thing that came in my mind was, we find digoxin in a plant, of course we're going to find some good stuff in us. What amazed me, we're presenting this to colleagues and them going, I should go to jail because I'm doing stem cells. And I'm going, I'm not even promoting it for advertisement, but to me the science made so much sense. And how silly is it? Okay, so I'm not putting the fat in, but I'm putting this part of the fat in. Ooh, that's dangerous. I mean, this is where I say, I think as physicians, we sometimes do more disservice to innovation than we do in general, and it's not just doctors. I just think that we need to be open-minded rather than fearful of things that we don't understand, be open-minded to learn about them, because quite frankly, it's been 20 years since I've been focused on this, and I'm finally at a point where I actually think this is going to start to fly.
That's my
20
point.
years.
That's my point. So Alyssa, how
We're here.
fast is 5 years?
We're
It's
here.
Like this,
Yeah.
right? It's so we would almost have to be right there right now, because 5 years is a blink. Grant, same thing, right? 5 years is like nothing. I guess it's a sign of getting older, but it's this is going to be more than a 5-year project.
Awesome. Well, one very important question before we leave for lunch. So Dr. Bucky, for those of you that don't know, he's an avid horse race fan. So who's your pick in the Kentucky Derby?
Charge it.
All right. I'm putting my money there. Thank you all.